We are live. All okay, ma'am.
Okay, a very good evening, everyone, and welcome to the session 3 of Guru Sangam 2025-2026 edition. And today we will be discussing quality systems and communication skills. As discussed today, even in the morning webinar, this is a very important segment, and we're looking forward to the session. I thank the AIS dignitaries, especially Dr. Partha Viswas sir, for organizing this wonderful session, Dr. Santosh Unavi sir for designing it, and for Dr. Manoj Chandra Mathur sir for backing it up always. And we have our speakers today, Dr. Nirmal Frederick from Nirmal's Eye Hospital, Chennai, Dr. Vijay Bhaskar Gajala from Shankara Eye Hospital, Guntur, and Dr. Pushpa Kumari ma'am from Jayaprakash Hospital and Research Center, Rourkela. We have an expert panel consisting of Dr. D. Chandrasekhar sir from Arvind Eye Hospital, Coimbatore, Dr. Kirti Singh from Guru Nanak Eye Center, Mansi, New Delhi, Dr. Mohita Sharma ma'am from Tirupati Eye Center, Noida, Dr. Prakash Marathi sir from Netra Yogi Eye Clinic, Pune, Dr. Samina Zamindar ma'am from Zamindar Microsurgical Eye Center, Bangalore. And we will be covering topics ranging from implementing the quality systems in ophthalmic practice, sterilization of the ophthalmic instruments, communication skill, and how to break a bad news, and clinical optics. And if I can say, sorry, clinical optics will not be covered today. So if I can say that these are very important topics which are being addressed, and I look forward to the discussions. And we have our moderators, Dr. Farnaz Khan, Center for Sight, Hyderabad, and myself from Mahatma Gandhi Medical College, Jaipur. So, over to our first speaker. Uh, Let me unshare my screen. Now, may I request Dr. Nirmal Frederick, sir, to please share his screen and talk about implementing quality systems in ophthalmic practice, a comprehensive approach.
Thank you, Dr. Olika.
Right.
My slide visible? Am I
Yes, sir.
audible? Yeah, thank you
Perfectly.
so much. So, good evening, everyone, and thank you for your leadership, our expert panelists and moderators here. It's indeed a wonderful Sunday to talk something about my pet topic, quality, starting point of journey called excellence. And it perfectly gels with the theme of Guru Sangam, educate, elevate, and excel. So educate happens in medical colleges and continues in professional circles and associations. But elevate and excel, we have to get involved beyond our regular education, that is the professional education, and beyond the medical college curriculum. So implementing quality system in ophthalmic practice. So this talk is designed for the beginners and our young ophthalmologists. So have certain, right, so let me start with my disclosure. I work with NABH and Quality Council of India, and also been involved in creating the privilege of creating and working on the NABH ICAT standards 1 and 2. We're also involved in a few other accreditation agencies. And basically all these are honorary and no commercial conflict of interest. And all the views based on my professional experience of implementing quality system at our hospital and assessing over 350 hospitals across India and elsewhere. So to start with the theme and try to teach people about the concept and the new theme, we have to start with this thing called why. So beyond why quality, why implementing these quality parameters, I will also be covering the other W's, what, who, where, when, and how to implement, so that we can get a complete coverage of roadmap to quality excellence. So why should we learn and implement quality systems in ophthalmic practice? I put across this question in a young ophthalmologist group. And there were some interesting answers and comments. And one comment was related to this, the media headlines, which are shocking on an everyday basis. All these uncommon errors have become common errors for media people. And they project as if these errors happen on a day-to-day basis and vitiate the atmosphere. And whenever I open infection control or put something related to medical legal cases, so this case jumps up with all this main allegation against the hospitals and providers. And of late, we've been hearing this in the WhatsApp groups, unemployment, small hospital closures, and this one, medical education revamp back to the Gurukul systems. So what is the root cause of this negative portrayal by media and the other subgroups? So basically, these are the three issues: the lack of skills, particularly related to patient safety and infection control, and certain things not taught in the medical legal, in the medical colleges, the medical legal and practice related challenges. And of course, the result, what we've seen and hearing the last few days, the unemployment among the doctors, and doctors being not ready for practicing their profession even after finishing their post-graduation. This is a huge critical gap which nobody talks about. And so this the gap I'm going to address. The paradox of doctors and employment, maybe it does not come to the specialty side so far, but it is projected that there will be massive unemployment by 2030. And the new doctors coming up are reluctant to practice because of rising operational cost or not being confident. So the root cause is medical colleges and postgraduate institutions train doctors in clinical skills, but there are certain other skills that is required for practice: infection control, management basics, patient communications. So all these are being clubbed together in today's session, particularly infection control and patient communications. And maybe this talk will cover the overview of these gaps. So new graduates lack confidence and skills to start independent practice. So this actually the question I put across to some of my youngsters: how many of you received formal training in running an ophthalmic practice? There was a silence for some time and no hands up. So this is the status, and this is the gap we have to cover. So we do teach a lot of clinical ophthalmology, surgical skills, diagnostic techniques, and academic research to give clinical competence, but practice unprepared doctors. But what practice needs and what I have learned over the last 30 years in practice is academic curriculum lack these practice setup and management skills, financial planning, the insurance navigation. So being in the insurance committee, I get a lot of complaints and redressal, grievance redressal emails from our members. So HR and team management and reputation management. The result is fear, hesitation, and preference for salaried jobs. So we spend years mastering surgical techniques, but produce graduates who are unprepared for running a safe, efficient, sustainable, quality, and legally compliant practice. And these are the top 10 challenges in practice received through a survey, starting with leadership skills and regulatory issues to communication, infection control, auditing, facility management, managing the staff, and the medical legal challenges. And these are the things they fail to teach you in medical college. And this is where professional association and these kind of programs hope to address the gap in this curriculum. So this isn't a criticism of our education system. It's simply acknowledging that clinical excellence is only one part of a successful ophthalmologist. And this vacuum in ophthalmic education is real and it's a universal. It's not only limited to India, but also elsewhere. What is the cost of this gap? We can see that medical legal crisis, 400% increase in the cases, medical legal cases. insurance claim rejection and issues with the insurance providers, and the sentinel events. So continue to increase. We continue to see cluster endophthalmitis. We continue to see wrong site operations. We continue to see hospital being closed up with financial losses and inefficient practices. So what we don't learn, we pay for, and we pay this in heavy way. So how can we address this skill or knowledge gap? This is where the systematic quality system comes, which can address and offer protection from all of these challenges. And this is where this theme has become close to my heart. And I'll try to focus on this, how we can elevate the youngsters and make them excel in practice. So what is quality? Doing the right thing the right way every time. So this is very important, not only occasionally when somebody is observing or supervising, but also every time. And this actually relates to clinic excellence and give good patient experience, and also improves our operational efficiency in private practice, and also teaches about leadership and governance. So quality addresses all top 10 practice challenges. And this is not just paperwork or bureaucracy. Accreditation framework prove what you do, protect you when challenged, and empower your team to deliver excellence. So this is where accreditation is now the new buzzword in practicing circles. So I'll just take you through the complete roadmap to quality excellence, what we call as accreditation journey. A brief highlight on the work the premier accreditation agency in the country has done. NABH was established in 2005, and after a great struggle in 2015, 10 years after it was established, we bought the first specialty specific standards in 2015, launched at the AOS headquarters in 2016. And over the last 9 years, about 1,500 eye hospitals have been accredited and migrated from the general hospital standard, which had challenges. And now in the last 2 months back, we launched the second edition during the National Patient Safety Day. Unlike general standards, NABH eye care standards understands eye care, understands our ophthalmic workflow from OPD to OT, from admission to discharge, and from audit to accounting. So this was designed by ophthalmologists for ophthalmologists of India. So why it was created? The old standards or the generic hospital standards was like wearing someone else's clothes. It sort of worked, but never quite fit into ophthalmologic workforce. But now ACO Standard 2, designed for ophthalmic workflow, it's practical and comprehensive, and built from the ground reality of doing 1,200 accreditation, their feedback and inputs to make this comprehensive. So what TCO standards address is ophthalmic specific questions, the role of optometrists and allied health staff, the reusable instruments and consumables. Optical dispensing has been included in the quality assurance, and also gives protocol and standardization of imaging to infection. And of course, we are going one step ahead and giving surgery outcome quality indicators, patient-reported outcome measures, and patient-reported experience measures, so that hospitals can go one step beyond accreditation. And this applies from single doctor clinics to large tertiary centers. So comprehensive enough to cover everything and practical enough to actually implement by single doctors to the large eye hospitals. NABS has 10 chapters, and these 10 chapters really help us to address the top 10 challenges. So patient being the center of this 10 chapter framework, all these chapters are linked together. And so basically these 10 challenges in practice can be addressed by the 10 chapters. I will not go into the details of the chapter because it's a voluminous work, but I'll see that you can understand quality and NABH standards in a short framework. So these 10 chapters are divided into two parts. One is patient-centric, another one is management-centric or organization-centric. And the first 4 chapters, ASC, COP, PRE, and MOM, talks about the accessibility and continuity of care of patients, and patient rights and education, and management of medications. So these are patient-centric standards. And the next two are safety and quality related standards, infection control and continuous quality. Uh, continuous quality. The last four are related to the facility and infrastructure. So it's a complete integration from first contact of the patient to the provider to the final follow. This is the prototype standard or the first chapter, access, assessment, and continuity. So this deals with how the patient access our organization and what is the assessment being done in the center, both general, optometric, and ophthalmic assessment, and how the care is provided in a continuous way, including the support services, and if there are emergency during the process, how the organization handles. So if you can implement this, there is a 40% reduction in assessment time, and also emergency patients are attended in a proper way, and that increases the patient satisfaction by 20%. Signages are a very important aspect of this chapter. This actually helps the patient understand and come to the organization and reach out to the right scope and right service at your hospital. It also smoothens the service encounter and patient journey across the hospital, right from arrival to admission to discharge, and in between the treatment and the processes, and of course the payment and feedback. So the entire journey is taken care of this under the standard. Beyond this, the patient-centric standards also addresses optimization of resources and the care of patients in the hospital to reduce the medical legal risk and improve patient care. This particular chapter, and I'm sure Doctor would be discussing this. So basically, we are not taught to handle special situations in the hospitals, like breaking bad news, handling the adverse event, handling an aggressive patient or a group, or talking to a family who has lost vision or expired, or counseling for a complicated intervention. So this communication with the patients, for patients, everything is a negative news. Including the investigation cost as well as the type of procedure. And particularly if you are explaining the comorbidities, they are in a very difficult position to understand. So this handling special situation is an important framework that is part of NABH accreditation. So this actually needs enhanced communication. I will not go into the details. Right. So medication management, of course, this is a real case scenario. We had one patient given atropine instead of tropicamide for dilatation. So the result is patient couldn't see near for 10 days, and they made a huge ruckus in the receptions. So the junior doctor said it was the nurse's fault. But being a standards promoter, what we went across is, did you have a system to prevent this? So then came all this management standards, MON standards to the rescue. So the reason was similar bottle, same shelf, and junior nurse was not trained to deal with this drops and doesn't understand the drops. So we implemented this look-alike, sound-alike principle, and a high alert medication required double check by two people before administration, and also focused on the FIFO system. The result is zero medication errors in the past 18 months. So the NABH chapters help in not only addressing the present concerns, but also preventable complications are addressed. The important standards are management of medications and infection control. I'm sure the next speaker will be focusing on infection control. I will not go into the details, but these are key issues: drug storage and labeling, high-risk medication protocols, and certain error prevention system to reduce errors with medications. And endophthalmitis prevention is a key area, and because it is also related to consumer protection cases in a big way, particularly if it is a single case, it not only destroys patient vision, it also destroys hospital reputation. And if it is a multiple case, the problem is multifold. So before and after implementations, so our systems have changed. Our medication management has come down. Errors have come down. There is 100% fee for compliance. There is no dead stock in the pharmacy. And the pharmacist and the nursing team have learned about the medication management. Same way, our hand hygiene compliance has increased. And there is a proactive reporting about any healthcare related infections. We also implemented this checklist methodology, so which use the EMR to address the documentation issues. It has reduced the time, errors, and complications are also documented. It has helped in a big way in auditing our outcomes. The quality indicators are part and parcel of the quality system related to NABH standards. So it also tracks not only the important indicators, but also the patient feedback and satisfaction indicators that helps us to improve our service standards. The other management related standards, the human resources, helped us to improve our credentialing and privileging process and also do performance appraisal system and retain good staff with our organizations. It also taught us about resource allocation and budgeting and also how to empower the team for a sustainable growth. And more important is the facility management. The standards helped us in understanding equipment calibration, the importance, the biomedical waste separation, as well as the more important fire safety in the hospitals, as we have a lot of equipments and also there are non-working hours where the equipment power is running and our air conditioning system is also working. So we have improved the fire safety and also improved the emergency preparedness with the quality organization. Last but not the least is the information system and medical records, which has improved a lot. We have a full-fledged EMR implementation with data security and backup and patient confidentiality with all the regulatory compliance. The safety in our facilities standards focus more on not only on the structural component, but also on the critical system like water supply, fire system, and backup medical gas system and communication systems. It also helped us to focus to reduce falls and accidents as we deal with a lot of vulnerable patients. So basically, quality has two components, and NABH standards have helped us to improve the service quality, so which has tilted the service delivery and client satisfaction to our advantage. So when should we implement quality system in ophthalmic practice? So the best time to start was yesterday. You don't have to do this alone. We have improved the system in officially as well. So we have a lot of resources in the NABH website. You can go and download the standards free of cost, including the guidebook. There are a lot of assessment tools which will help you. Training is offered on a regular basis. There's a course called Program of Implementation. The details are available in the NABH website. And there are QCI empaneled consultants to help and support. And you can always visit NABH accredited eye hospitals to learn about how exactly they implement and learn from the peer group. So basically, you can take action this week, open the NABH website. There is one resource called NABH Mitra and download the standards. And if you can any query, you can also contact us. So this is the NABH website. So over 25,000 accreditations now. And this is a wonderful resource site. You can see the ICAR organization accreditation program. And this is the second edition NABH accreditation standards. And this is the digital toolkit for hospital, which will be useful. So how do we start implementing quality systems? So who implements? Of course, the ophthalmologist has to be the champion and leader. And this basically helps to control the team as well as lead the team. Patients are our partners, and everyone spots problems early, including the patients and the last grade staff. So quality is everyone's responsibility. But as a clinician, we need to lead by example. So it starts with you as the ophthalmologist. So I'll just go through a practical implementation roadmap. So basically, it takes about 10 to 12 months. So starting with preparation, a gap analysis, so I'll just come to that, and then system building, training of people, and mock assessment. So basically, it takes over 10 to 12 months. So it's a 8-step process of implementation. So first is getting the leadership buy-in. So the doctors have to understand why before how to implement, and then appoint a good administrator or a doctor as a quality champion, and then resources and budget needed, and realistic timeline. And the medical director must lead and not delegate the survey. So if leadership isn't committed, don't start. So you can always postpone, because if the leadership is not involved, a lot of challenges will aggravate and get accumulated. So this is not a project you can outsource completely. So this is where doctor involvement really matters. So form a core team and various committee and address the gap. There is a self-assessment toolkit available in NABH website. You can download and use that to rate what is the gap fully met, partial or not met. And patient safety and medical legal have the highest priority, and always have some mentors to guide you through this process. And then documentation is very important. You need to build systems, patient safety protocols, and also the culture of adverse event reporting. We need to train our staff, but don't try to build everything at once. Go step by step. Documentation is very, very important. The key principle is to have certain policies, understand what and why the policies are needed, and you need to have certain simple standard operating procedure detailing the process on how, and also standardized forms to capture the real data and records as evidence of complaints. And so these are the common mistakes to avoid. Don't copy paste from other hospitals and make it very simple. Don't complicate the process, and always have ownership or review to the staff. And make the documentation pyramid very, very simple. So just 5 core SOPs are enough, and don't make it complicated. If nobody can follow it, simplify. And also, if people can't follow English, try to translate to your regional language. So regional language manuals and SOPs are acceptable, and it is easy to reach out to the last grade staff. Training strategies are important. So you need to have a comprehensive training program for our staff during induction, as well as refresher training for existing staff. And this is to make them understand why quality is needed and how we can improve quality on a regular basis. The sixth phase is internal audit. So we need to have regular audit in our hospitals, and also have mock assessment before NABH assessment or the final assessment. You need to have a review your document as well as interview certain staff, and also focus on system improvement. This mindset shift is very important during internal audit, and also ensure incident reporting is done immediately and fault finding exercise is not there, so and not hidden. A lot of challenges during implementation, particularly for small hospitals. So these are some of the challenges: too much paperwork, staff resistance. So you need to streamline this, make the forms very simple. Google Forms can help. Cost concerns from the management. So if the management themselves do and part of it, they will understand this. Time constraints definitely will be there. Start with higher risk areas and then go to the other areas. Documentation have to be simplified, and templates are really good. So what do I get? So what are the benefits? So basically, if we implement quality system, what do I get? This is a question every youngster asks and every doctor asks. So the need for hospital accreditation is important nowadays with all these challenges. So a lot of benefits, both primary, secondary, and multitude of tertiary benefits. And the certificates are only an outcome. So they speak louder than the words. So this is the way we progress from ISO to NABH, entry level to the regular accreditation, the fourth cycle. So learning beyond medicine. So quality systems teaches us not only these 10 challenges, but also beyond that, it helps to reach us to excellence in patient care, documentation, and fulfill all the regulatory compliance. NABH develops you as a leader. The accreditation standards are like guidebook for leaders, not only in team building, but also in communication. So it makes us to think in a system way and helps to formulate a strategy for our practice improvement and management, and also how to delegate with authority. So from overwhelmed surgeon owner to strategic healthcare leader. So this is a big benefit. The third is patient satisfaction and feedback. So these are our Google reviews, and patient votes as voted as a trusted hospital and by Reader's Digest. So these are all certain benefits. We can publish and flourish and become a pioneer. So these are some of our quality related publications: patient reported outcome measures and quality assurance in ophthalmic imaging. The accreditation systems not only helps the practice, but also helps us to get involved in finances and accounting. So the third-party payers are willing to support your practice in a big way if you are accredited. And a lot of financial benefits and business benefit, not only the monetary wise, but also by reduced waste, retention of staff, and operational efficiency and reduce litigation. So this happens over a period of time and give the multitude of benefits. It's a very good branding tool and benchmarking tool. NABH itself brands your hospital as well as it tells patients about the quality framework. It also promotes your hospital in a big way through websites and other media. Medical legal defense, as I rightly said, it helps to avoid medical legal problems. So not only regulatory, but also the other administrative errors and failure of communications. So basically, quality standards transform you from a uh, academic professional to a complete professional, from clinical training, surgical skills to professional excellence. So where systems and processes are based on your practice. So basically, quality standards is a win-win for all stakeholders, not only patients and families, but also staff, directors, board members, and the community partners. It increases and gives better outcomes. Initially, it is a pain, but over a period of time, it improves increase efficiency, quality, and safety, and reduce risks. So basically, the initial cycle may be pain, but once you maintain the accreditation, there's a lot of gain, and these are the tertiary benefits. So the critical gap nobody talks about. So one solution is quality system. We can bridge the gap through systematic training and practice management, patient safety, and business fundamentals. And the path forward. So you are the generation that can change Indian ophthalmology. So transform education to create confident leaders, confident practitioners, and let us solve the unemployment and healthcare access. So these are your next step, and all the best for the excellence is the way of traveling. So start your 1% today. 1% today, and for the next 365 days, it gives a compounding benefit. Thank you so much for the opportunity, and gratitude once again to the expert panelists and the AWS leadership.
Thank you so much, sir. These were absolutely useful tips and tricks, and I think you have, enlightened all the postgraduates as well as ophthalmologists, young ophthalmologists, old ophthalmologists. You've covered all categories. I absolutely agree. Dr. Prakash, sir, can I ask you for your inputs on this topic?
I think it was very well elaborated by Dr. Nirmal. It is not only the clinical acumen in your practice, it is not only surgical or investigations, but it is the quality. And nowadays, it is needed not only for flourishing your practice, but basic needs. These are the basic needs by government rules and regulations, like NABH accreditation, then JCI, and all that. And probably, if you are coming into that, that is definitely going to help your practice. And as Dr. Nirmal has said, when to start? I think it was yesterday. And if
Yesterday.
not yesterday, it is today. So most of the times, youngsters, they feel that when I become senior in my practice, probably I'll be thinking about this. And then that tomorrow never comes. So basically, if you start from the scratch and you start your practice with these basic things, like selection of a place, like your clinic, and then infrastructure of your clinic, if it is in the format of NABH, probably it will take you to the heights of your practice. The basic example, what he said, that instead of Tropica, my diatropine was put. I think simple thing is that that junior nurse has to show that bottle to someone else, the senior. The senior may not put those drops to the patient's eyes, but she was supposed to show that to someone. These are the basic things, and I think NABS takes care of all those things, all these basic things. To start with, you may feel that it's very difficult, but then definitely quality starting in your practice definitely is going to help you in your future. So basically, start today and not for tomorrow. Don't wait for tomorrow. That's what I feel.
Absolutely, sir. Dr. Samina, ma'am, can I request you for your inputs as well?
I think that every ophthalmologist who comes out after the post graduation should listen to this 30 minutes talk of Dr. Nirmal Frederick. It should be become mandatory. But it's so wonderful. I never fail to learn from him. And I think what he said that this is the only way you can turn into a strategic healthcare leader, the transition from an overwhelmed surgeon to a strategic healthcare leader. I have seen a huge difference in my journey after I've taken the NABH and the quality route. And I'm very proud to say that Dr. Nirmal was my first assessor. So thank you, sir, for all what you continuously do. So thank you very much.
Thank you so much. I think I agree with Samina ma'am. In fact, this should become a part of the curriculum for all postgraduates as a mandate to go to the next step so that they understand that this is a part and parcel of life and they should understand it way ahead in their career. So I agree with you. Dr. Chandrasekhar sir, can I request you also for some
Yes,
pointers?
Dr. Olika. So normally the panelists are experts who comment on the speaker's talks. Here we have Dr. Nirmal, who is an authority in quality for the longest period in India. So he has been instrumental in getting all the standards. So I learned from this how to talk exactly to 30 minutes correctly. That itself is a quality. And he
Yeah.
covered a huge number of topics. It was not only the quality, he also made sure that we understand how it is going to be for the safety for the employee as well as the patients. So this is a wonderful talk, Dr. Nirmal. I do not want to comment anything, but as Dr. Zamina said, we have to do a post program marketing and share with all our PG groups and fellows that this is a talk
Absolutely.
wonderfully done to be listened to. So thank you so much for enlightening us. It was almost like a second edition refresher, Dr. Nirmal. Thank you so much. Thank you so
Thank
much.
Thank you so much, sir. Thank you, sir, for this wonderful talk. And I think I will watch it again because I think I need to take out some pointers so that I can follow it in my practice. Thank you, sir. And now we move on to our next topic for the day, and that would be sterilization of ophthalmic instruments by Dr. Vijay Bhaskar Gajala, sir. So over to you, sir. And I think the topic sterilization is so important in the current scenarios because I think in different setups, different steps are being taken up. And as I was overhearing the other day that many places even use Sidex, but Sidex is now getting banned. So I think it's kind of important for everybody to understand the actual way of doing it. So over to you, sir.
Hope my screens are visible and my
Yes, sir.
voice is clear.
Absolutely.
Good evening, everyone. Thank you, AOS, for giving this opportunity to talk on a topic which is often ignored during our post-graduation and training time, that is sterilization of ophthalmic instruments. There's no conflict of interest. Why I'm telling this is a special topic, the reason is this fact. We all know how to do surgery before knowing how to clean and sterilize the instrument that we use for surgery. Am I correct? So why we should know about the sterilization of ophthalmic instrument and operation theater? The reason is this picture, the postoperative endophthalmitis, which is a dreadful complication of any ophthalmic surgery and a nightmare for all ophthalmologists. So there are several factors for the postoperative endophthalmitis in a perfectly done and clean case. Among them, so there are few risk factors that we cannot control. It's not in our control, like contaminated irrigating solutions, contaminated IOLs, viscoelastic substances, and postoperative patient care. All these things not in our control. But what is in our control? That is 100% hospital management responsibility, where there should be 0% error, that is operation theater and instrument sterilization process. Okay, there should be no look back regarding this sterilization part. So, but before going into the topic proper, let's discuss how our ophthalmic instruments are different from other surgical specialty instruments. Our surgeries are mostly microscopic surgeries, except few oculoplastic surgeries, and we deal with the delicate structure, and the unique demands of ophthalmic surgery are fulfilled by a special instrument, which in size they are much smaller and designed for microsurgery. And with fine tips, spring open mechanisms, that ergonomic design is useful for better maneuverability under microscope. And precision wise, the unparalleled accuracy and fineness is important. Even in a slight deviation in this can impact the outcome results. And one more most important difference with the other specialty instrument is ophthalmology is a galore of halo instruments. Daily we use a lot of halo instruments like phaco handpiece, tips, Cinco, bimanuals, and vitrectomy cutters. So this small structure, complex design, fine instrument, halo instrument makes this cleaning process and sterilization process very complicated. And one more important thing is contamination risk. Even a minute amount of contamination can be tolerated elsewhere in other specialties, but not in ophthalmology. It can create severe intraocular inflammation. So the cleaning protocol should be extremely strict. So let's enter into the cleaning sterilization part. Sterilization means not just sterilization, it's a part and parcel of cleaning, disinfection, and sterilization. The cleaning means removal of visible dirt, dust, and organic matter. And the sterilization is a process which eliminates all microorganisms, bacteria, fungus, virus, and including spores. So instrument cleaning is the most critical step for sterilization. Let's discuss when we should clean, with what we should clean, what is the process, how we should clean. When do you clean? The answer is immediately after surgery. You should not wait for them to dry. The reason is in ophthalmology, these materials like lens matter, viscoelastic substances solidifies very fast. It makes it difficult to clean after that if once it becomes a dry. So the importance of immediate cleaning of surgical instruments is first, it simplifies the cleaning process because it's easy to remove when they are moist and prevents the bioburden from drying like blood, tissue, and fluid, even though it is very less in our surgery, but still. And it stops biofilm formation. Once the biofilm formed over the surfaces, it resists the standard sterilization technique and it prevents the instrument corrosion. Any biological fluids which contain the salts can cause the corrosion and pitting. That leads to metal fatigue. Even a minute stress can lead to damage our delicate instruments. And finally, it mitigates the patient safety risk. So what type of water we should use for the cleaning? And critically, the sterile distilled water, reverse osmosis, or deionized water, you can choose anything, but try to avoid this boiling and running water. Of course, we are not using nowadays, but still we should remember that. And what should be the type of cleaning agent or disinfectant we use to clean the ophthalmic instrument? And for the initial cleaning, the cleaning agent should be non-toxic, non-abrasive. It creates the low form and easily rinsed off, which is effective at breaking down bioburden. The first one is neutral pH detergents. These agents are formulated specially for delicate instruments. They prevent the corrosion and damage. And the most important thing is if any residue of these and neutral pH detergents is still on the, after cleaning, still on the instruments, the risk of toss is very less with these neutral pH detergents like Bodedex 4, Belimets, ophthalmic neutral agents. And the next one is enzymatic detergents. These detergents are very effective in cleaning and break down this bioburden, all types like proteins, carbohydrate, fat residues. And it works best with warm water. You should not use the hot water because the hot water can cause coagulation of these blood products. But it is always debatable that is it really necessary for the usage of enzymatic detergent in ophthalmic instruments cleaning, because we create very less bioburden during our surgeries. And these enzymatic detergents creates a lot of tasks like the post-operative inflammation chances is very high with. So if it is not really needed, and if you have a protocol that you can use it weekly once, and better go with neutral pH detergents instead of enzymatic detergents. There are several enzymatic detergents are available like 3M Rapid Multi-Enzyme Clear. We frequently use that one. And what are the things that we should avoid for the cleaning of instruments? Like harsh chemicals, like hydrochloric acid or iodine, we should not use because they may cause damage to the instruments. And alcohol-based cleaners, hot water, as I have mentioned, use warm water, not hot water. Let's come to the instrument processing. How to do? We can do it in 5 steps. The step 1 is cleaning and rinsing. Once you receive the instrument from the operation theater, you should clean it under running RO water. Number 2, prepare your detergent solution. And the third is If any visible dust or bioburden is there, you clean with a clean brush. And the fourth one is mop and dry those instruments. And finally, prepare this instrument for sterilization, that is packing. So let's discuss each step one by one. The instrument cleaning. So first, segregate different types of instrument, all instruments like the sharp instruments, hollow instrument into the different bins. Then you prepare your neutral pH detergents, whatever the detergent that you are using. Please always follow the manufacturer guidelines. Whenever mixing this, please make sure that it should not be estimated volume, it should be a measured volume. Because like 2 cups of detergent in 1 bin of water, it should not be like that. It's a 5 ml or 10 ml. As per the manufacturer guidelines, you should measure and mix it. The reason is we are dealing with chemicals. At the same time, we are dealing with the delicate structures. Even increase in the concentration can lead to severe inflammation. And later, then you should clean all the instrument and running over water. Make sure you look for the debris at the ridges, the hinges, all those things, and immerse those instruments in a prepared solution. Later, after again you rinse it under running water. If any visible dust or anything, please use a clean and brush and brittle brush to clean the instruments, and make sure you should not damage the tips of those instruments. So if you are using the brush multiple times, make sure and you should disinfect at least once daily those instruments. Once the cleaning thing is over, and you should keep the instruments or the clean cloth, it should be away from that cleaning area, and inspect for any debris or damage after cleaning. If you find any debris in this one, don't hesitate to send it back for the further cleaning process. Always use sterile clean cloth, and you can allow these instruments for air drying before preparing the pack. And if you want this instrument fast to prepare the pack, you can use this high flow jet air gun to dry very fast. After that, the real challenge. As I have mentioned previously, ophthalmology is a galore of hollow instruments. The cleaning of hollow instruments is the real challenge in our specialty. So we cannot clean inside the tubings effectively enough. If you don't clean it properly with any microorganisms inside this tube, and if you don't clean it, this viscoelastic or can create the film-like structure, biofilm, and it prevents the microorganism for the exposure to the sterilizing agent. So even after sterilization, so that process, this microorganism remains alive and it can cause infection. So that's why it is critical to clean this hollow instrument properly. We should have a proper protocol for this cleaning. So for the Cinco cannula, you can use the 10 cc syringe. You can flush it multiple times. When you are flushing, make sure that the effluent should go to the bin or separate bin or sink, and avoid the splash of this effluent on surrounding structures. And when you are using the phaco tubings, which is a longer one, this 10 cc syringe is not sufficient. You can use the 60 ml syringe or 60 ml distilled water should be flowed through this phaco tubings, followed by the compressed air for better cleaning of inner surface of these tubes. And the most commonly used instrument, that is phaco. So we should take special care when you are cleaning the phaco handpiece. You do not flush the phaco handpiece. So instead you should aspirate it. So that's why you can not damage these crystals and inside surface of the phaco handpiece. And make sure this the motor and the cable should be away from this bin, and try to avoid this becoming wet. So what are the do's and don'ts when you are cleaning this phaco and other instruments? So to rinse the phaco handpiece, you should not use any metallic brush to clean it. And visual inspection and touch-ups is needed. And do not overlook, not only for phaco handpiece, for every instrument that is important. And dry before plugging it in the phaco emulsification equivalent. You should not use the wet handpiece directly. So refer to manufacturer guide. So this manufacturing guide we should follow for the usage of detergent, for the cleaning of instruments, and also for the mechanism, to operate the sterilization equipment. So then at the end, you should prepare the set. So prepare complete set for a specific surgery. So some places they have a habit to clean and send the sterilization just like a bulk. All instrument, they will keep it together. And instead you prepare a separate for each surgery, like phaco set, vitrectomy set, DCR set, and keep the sleeves. You can use this IV tubes and you can cut it into multiple small pieces and cover those delicate tips of these delicate instruments. This is the IV tubing. You can cut it in multiple small pieces. So for delicate instruments like dialers, choppers, and heavy IA handpieces, all those things we should cover with these tips so that we can avoid the damage to these tips. And one practical thing is, if you don't prepare the sets, if some instruments are missing in that particular set, the sterile sister will go and open the another set, and there is a chance of cross-contamination. So always try to confine the instruments, things, everything for that particular surgery only. You should not, you should try to avoid the contact with other instruments and keep indicator inside at the end. So let's discuss these indicators in coming slides. And finally, once the set is ready, then we'll go for the sterilization proper. So there are different types of sterilization techniques are available. There are the physical methods and chemical methods. In physical methods, the heat sterilization, radiation type, and filtration. In the chemical methods, gas and liquids. And I'm not going to talk about the all methods right now. We are the most commonly used and the effective sterilization technique and sterilization process of ophthalmology is pressurized steam, that is autoclave sterilization. Another one is gas sterilization, that is ethylene oxide sterilization for the instrument which are heat sensitive. What is moist heat sterilization? It is one of the most effective methods of sterilization where we use the steam under pressure which act as a bactericidal agent. The mechanism is the moist heat sterilization works by using the steam which denature the proteins, enzymes, and disrupt the cell membrane, which leads to death of these microorganisms. The instrument that we use for sterilization with the moist heat method, that is autoclave, it works on the Boyle's law. The principle is pressure is directly proportional to the temperature. At atmospheric pressure, the boiling point is 100 degrees. If you raise the pressure up to 15 pounds per square inch, the boiling point will reach to 121 degrees centigrade. So to create the moist, you need to increase the temperature up to 121 degrees centigrade. If you expose these instruments for the 121 degrees centigrade for 20 minutes, that is sufficient to kill all vegetative forms. That's how this autoclave works. Not going into the mechanism of this autoclave proper. So if you want to reduce this contact time from 20 minutes to 10 minutes, the thing what we need is we need to temperature. For that, automatically we need to increase the pressure. Like for 30 pounds pressure, the temperature the boiling point will go to 132 degrees centigrade. At that level, the 10 minutes of contact period is sufficient to kill all the spores. That's how autoclave works. There are different types of autoclaves. Based on the design, there are pressure cook, vertical, horizontal autoclaves, and a table mount of autoclaves. And based on their mechanism, that there are class N, S, and B type. The most effective one are pre-vacuum sterilizers, where the vacuum generation is, vacuum creators is separate and the steam creators there is a separate, which is effective when compared with other types of autoclaves in sterilization of instruments. So how do you prepare these instruments for the autoclave sterilization? So this is the packing method. The packing is partially influenced the sterilization also. The packing should not be too tight or too loose. Usually, ideal is the double packing. When you are packing, always make sure, as I have shown in the previous video, keep indicator inside the box. At the same time, you should put a autoclave signaling lock or type 1 indicator over that one. So this is how you should prepare your pack before sending for the sterilization process. Make sure all these drying of the instrument, preparation of the set, packing, all those things should be done away from the cleaning area in a clean room. Once the set is ready, so now we'll keep all the packs inside the autoclave chamber. So this is called as loading. So loading is also important. How you are keeping these packs in an autoclave chamber, that is also important. Once you keep it, you should close this lid, and you can already prepare the pressure, temperature, everything. You can prepare a program or you can manually enter into the autoclave. And make sure the lid is tight and you can add the program. Now the sterilization will start. How much temperature, how much pressure, and what is the contact time, that all thing you can preset in this one. So what are the things that we need to keep in our mind regarding autoclave sterilization is we should not overload this chamber with multiple sterilization sets. And this is the right way. So always keep the heavy load in the down and lighter load in up with the proper spacing between these loads, and which allows the steam to penetrate through all the packs. And whenever you're using halo tubings, as I mentioned, this we'll use a lot of halo tubings. How to confirm this moisture is can able to penetrate through the complete tubing, that halo structure, and sterilize the inner surface too. For that, we'll use PCD, that is process challenge device. Here we are challenging that process. In PCD, it's a long tube. It's one end, there will be an indicator. If the moist is able to passes through the complete tube and reach the another end, there will be a change in the color of this indicator. That indicates that that sterilization process is effective in cleaning the sterilizing the inner surface of this halo tube. So you need not use in every load of these halo instruments. In between, for the confirmation's sake, you can use intermittently this PCD, process challenge device. And one more important thing, once you receive this post-sterilized packs, make sure there should be no wet moisture over these packs. So this moisture can act as a vector for these microorganisms during the transport process, during the time of the storage, all these things. So is it possible to sterilize all instrument by moist heat sterilization? No. There are a lot of instruments in ophthalmology which are heat sensitive, like biometer lenses, laser system, the probes, thermal cauteries, electrocauteries, fiber optic instrument like endoilluminators. If there is a reusage policy of the blades, which with the plastic handles like diamond nose blades, which are heat sensitive, so those things we cannot sterilize by autoclave method. So we need a separate method. So we need to choose alternate, that is the gas sterilization method. The gas that we are using for sterilizing agent as a sterilizing agent is ethylene oxide. It is the alkylating agent. It works when it exposes to this microorganism, it chemically reacts and destroys these microorganisms' DNA and proteins, and preventing them from reproducing. So, and unlike the autoclave sterilization, it is a low temperature process where usually the temperature will not exceed beyond the 60 degrees centigrade. And the main advantage is that we can put large volume of packs inside the ETO chamber. So the sterilization capacity is very high. And one more thing is it is non-corrosive to different metals like rubber, plastic, and metal products. But there are some disadvantages. First thing is it's a large cycle. Usually the autoclave will finish it within 20 minutes. But in ETO, we need minimum of 12 to 14 hours for the completion of cycle. And main important thing is safety issue. These gas is toxic and carcinogenic to the persons, and it's a highly flammable. And one more thing is for the setup of this ETO equipment, we need a separate structure. It should be the top floor of the building. And the packing of this ETO is totally different from the moist heat sterilization, where this ETO packing, one side is a transparent cover, another one is there is a porous sheet, so which allows the transfer of this gas while preventing the microorganism entry. So now sterilization process is over. How to confirm the sterilization process is effective or not? For that, we have indicators. These are sterilization indicators. There are different types. Physical indicators, chemical indicators, and biological indicators. These physical indicators are nothing but these parameters like sterilization cycle time, how much temperature, whether using, and the pressure, and all those things, whether this process is happening, it's perfectly or not, we need to record all those, the physical indicator things. And the chemical indicators, this is the visual confirmation thing. There are different types of chemical indicators. When these chemical indicators expose us to this sterilization process, due to the chemical reaction, there will be a change in the color of these indicators. There are from type 1 to type 6 are available, but most commonly used one are process indicator, that is type 1, where that is that in previous videos I have shown that the system will place that auto signaling log tape over the packets. So it distinguishes between the process and non-processed items. And another most important thing that we use is integrating indicators, where we keep inside the said. So react to all critical variables like sterilization process, like time, temperature, and pressure. If everything done perfectly, then only there will be a change in the color of this indicator. And type 2 is a specific user. Usually, commonly we use the Bodex test, where whether the Bodex test is type 2 indicator to confirm that the vacuum is completely created or not, the air is completely removed or not. So like that, for the each purpose, the different types of indicators are available. So you can see in this picture, after the sterilization process, there is a change in the type 1 indicator and type 5 indicators, the ATO indicators color. So only when there is a change in the color, you should accept those instruments. If there is no change in the color, please send it back for the sterilization department. And the type 3 is, and the third one is the biological indicator, which is the gold standard of all, where it is a flexible plastic vial. Inside there is a glass with medium, and outside there is a sports strip. This sports strip contains the um, Geobacillus stereothermophilus bacteria, which is highly resistant to the heat. Even if the and you should keep this vial along with the load. And once you receive after sterilization process is completed, to squeeze this vial, it leads to breaking of this glass sample, and the medium will come out and mix with this sports strip. So now you send it for the incubation. After that, if you observe any growth of this bacteria, there will be a change in the color. So that means the bacteria is remain viable, that remain alive. So the sterilization process is not effective in killing the bacteria. If there is no change in the color, the bacteria is already killed. So autoclaved objects are sterile, then we can accept this one. So it is not possible to use the biological. Of course, ideally we should use for every day, but if not every day, make a policy that at least weekly once you should use this biological indicator. There are different types for the autoclave and biological indicator, and DT also we should use this one. But ideally, not only one type of is a physical, chemical, or biological. The combination of all three types of indicators we should use for comprehensive monitoring. And most importantly, you should record all the test results and maintain those records, mainly for not only for medical legal purpose. And if you receive any loads without, recording the sterilization issue, you can go back and you can check and to re-verify the process, whether how it happens again. And finally, once the sterilization process is over, if everything fine, and we can store these instruments, and we can, for the moist heat sterilization, you can store this instrument up to 48 hours. And ETO sterilization, it can be useful till 6 months also. Always store in an open shelf, not in a closed area. And this shelf should be 8 inches above the floor, 2 inches away from the wall, and 18 inches from the ceiling. You should not touch the floor, ceiling, or walls. And it should not be stored in autoclave rooms where the temperature level is very high. The ideal room temperature should be 25 to 30 degrees centigrade, just like our operation theater temperature, humidity between 30 to 60%. What are the take-home points? The meticulous and immediate cleaning, as I mentioned, you should not wait for them to dry. So in any setup where there is a staff shortage, and if there is no dedicated person to clean immediately, then you can keep those instruments in a bin with the water. So don't allow them to dry. And use a critical water for rinsing. You do not use just like a hot water. Avoid routine enzymatic cleaners because they may cause severe toxic. But if there is a policy, weekly once is allowed. And make sure that even after using this one, all the residue of this enzymatic cleaner should be thoroughly clean. Follow manufacturer instruction both in cleaning of instruments and while using these cleaners and during the process of sterilization also. Implement quality control measures like indicators. You should not go back. You should not compromise in this one. And establish written protocols, and staff training is most important thing. So ignorance is not always bliss. If any mishaps happen, our patient will lose the vision. We lose our dignity and reputation too. Okay. That's it. Thank you.
Thank you so much, sir. Thank you, sir. And if it's a highlight, even my mom was watching it along with me. She was also like taking her pointers. So I hope it helps everyone. Can I request the expert panelists also to give some comments on the same? Prakash, sir, can we have a word from your side? So you're muted, sir. Yes, sir.
Yeah, Dr. Vijay Bhaskar, can you unshare your screen? Yeah.
Yes.
So I think all sterilization techniques were very well covered. Nothing has left. The only additional points I will talk about the theater atmosphere. I think that stability is also very important because
Yes.
we are presuming that that is perfect. That also has to be perfect. That's very important. Second thing is, it is the responsibility of the operating surgeon, though the staff is taking care of this. So, medical legal point of view, though you are not doing these sterilization techniques, I think you are also responsible. So, it is your duty to supervise all that. Then, next important thing is, as youngsters, PGs, if they are watching, all these procedures you must do yourself to start with, because not doing and telling your juniors all the time in your life, probably you are not that master in that particular technique. Unless you have done it yourself as juniors, means you really know the procedure. You should clean your instruments. You should sterilize your instruments to start with, like the junior resident does. In your clinic also, you must know before telling your staff. And next important thing is medical legal aspects. Like most of the consumables, when they are directly coming from the manufacturer and you are not sterilizing them, probably in that case, suppose the infection occurs or endophthalmitis like things they occur, I think whose responsibility is this? It is the doctor, it is the hospital, or it is the manufacturer. And most of the times, like consumables like visco and all that, if they are creating the trouble, it is very difficult to identify. And hence, if you want to escape from all those medical legal litigations, I think perfect documentation is must. Those indicators, what you have put after sterilization, those you should maintain with your records all the time. Like every indicator probably will tell that the sterilization technique was done in a proper way. I think after all these precautions, there are unfortunate incidences occurring in this country. And at that point of time, probably medical legal cell of AIS is definitely there for your help. So I wish all ophthalmologists not to have that particular situation, worst situation of infection in your life. Thank you. Thank you so much.
Thank you, sir.
Right, so I do agree, sir. In fact, maintaining a register of how often the instruments have been cleaned and which sets have been cleaned, and having a record that yes, it has been done by a particular person, even that would help in streamlining the process. Samina ma'am, would you like to give some inputs too?
I think I really enjoyed your talk, Dr. Vijay. Thank you
Thank
so
you.
much. It's a very meticulously planned talk, so thanks a lot. Just
Thank
wanted to
you.
bring out a few things. One is that the annual maintenance contract of the autoclave is a must. Like how
Yes.
you take an AMC for other equipments, please see that that is done. So routine maintenance, the staff has to learn reading from the manufacturer's manual, and the preventive maintenance, we will have to get the service engineers to come. And when the engineers come, it is important that you ask for a STP, a standard test protocol report, because they sometimes they just scribble something and go away. It should not be there. Calibration and many aspects of the maintenance service should be included. And if you are, as a backup, you should have one more autoclave with you,
Yes.
a class B autoclave, one more autoclave, because the autoclave there can be a breakdown, and this is considered as a critical equipment. So that
Okay.
about that. And another part is that your OT staff should be empowered. If there is a fail load, they should be able to recognize the fail load and also alert and stop the load to enter into the
Yes.
OT. So empowering the operation theater staff, giving them the due respect and credibility, and always sort of seeing that regular trainings happen for them is important. So thank you very
Yes.
much, Doctor.
Thank you.
Right. And I guess we have a question from the audience as well. What about the situations where you need a particular instrument urgently and you don't have the time to autoclave? What are your inputs for them?
There's one technique is the flash sterilization technique. We should not use it routinely. We use the high temperature and high pressure thing. So we can use within 10 minutes, we'll get that instrument with the flash sterilization technique. But don't use it as a routine sterilization process for that one.
Yes, and to be precise, putting an instrument in formalin and putting an
No,
instrument
no, no.
inside
It's
it
no,
does
no. This
not work.
formalin, these things are really, we should avoid all those things.
Yes. So I
Yes.
wanted that to be highlighted because a lot of residents in general, they do not know about this part that it's not okay to use
Yes.
an instrument which is just put in formalin.
And make
And
sure any instrument that you are using that should come in a properly packed thing and all the integrators, there is a change in the color, then only we should use that instrument. Even the open instrument, if somebody is giving, okay, use this, you should try to avoid this one. The finally we are
absolutely,
responsible for everything.
absolutely, sir. I do agree. And
To
Chandrasekhar, sir,
add,
Yeah,
yes,
yeah,
sir.
yeah. Yes, sir. Yes, sir. Please
Yes,
go
sir,
ahead.
Nirmal, sir.
yeah, chemical
Vijay?
sterilization is not advisable in any form, particularly intraocular instruments,
Right,
because the chemical cannot be clean 100%. It cannot be validated and it cannot be documented.
right, sir.
So the youngsters they do use in some institutions Cidex and
Formalin.
isopropyl alcohol or formalin chambers.
Absolutely.
It's absolute no for chemical sterilization
Yes, sir.
and
In
use
fact,
for disinfection alone.
correct. So you're absolutely right. The concept of these instruments being sterilized like that on an emergency basis in general surgery were different, but here you're kind of compromising the patient's vision. So I think everybody should be very alert before utilizing any of the instruments without going through the entire process. Thank you for highlighting
We'll
that.
make sure that even usually we don't put any postings rewarding CSST postings for the fellows or
Correct.
residents.
That is
So
so
it
true.
should be there in a curriculum also.
Yeah, that is so true.
Yes.
Absolutely.
I think
Chandrasekhar,
not
Yes,
only in the
Rolika.
curriculum, even before that. So any surgeon, if you want to be a good surgeon, you should visit the CSSD before coming to the theater and hand wash area. So
perfect.
that should be the important protocol. Change the dress, go to the CSSD area. Maybe in some hospitals, CSSD will not be within the theater complex. But ideal situation, ideal PG training should be like this. Change your clothes into surgical attires. Go and visit the CSSD, inspect the consumables and the instrument you're going to use. See whether adequate backup is available. Then only you should wash your hands.
Right, sir.
Yeah.
And in fact,
Yeah.
post the surgery is according to the presence of instruments. So make sure
No,
that
no,
your instruments.
it should be the other way around.
You must have the
If you
instruments
are
for the surgery.
posting 10 cases,
Yes,
at least have 30% backup. So at least 3 set of instruments should be there for backup. And same way
absolutely.
consumables also.
Absolutely, sir.
Okay, Rolika. So
Yes,
I
sir,
have a
your
few
turn, sir.
points. Now we call this immediate use sterilization techniques. So they do not have a storage time. We have to use it immediately. They are actually meant for drop-down instruments. Originally, they are meant only for drop-down. So there are a few points with the permission of Dr. Vijay Bhaskar.
Yes,
See,
yes, sir.
most of the PGs and not doctors themselves, they do not look at the indicators at all.
Yes,
So they look at that class 1 indicator. Most of the hospitals may not have a class 5 in every set. And when they see the color change, if at all they know, they think the set is sterile. It is not so. The
yes,
class 1 only says the sterilizer has been switched on for at least half the period. It does not say it has been sterilized completely.
yes.
It is only the class 5 or the class 6 which will tell the proper process has been undergone. So that is actually, as Nirmal said and Dr. Vijay, they must go learn that first. And there are about 60, 70, 80 people, like Dr. Vijay Bhaskar, he may know that there are 70, 80 people involved in the whole process, but something
Yes,
goes wrong, it is the doctor or the surgeon or the head of the institution.
yes.
So that is going to be, you have to know it and you own the patient and do it. So do you use ultrasonication?
Uh, there's a weekly ones for
Mm,
especially for the this hollow instruments. We will
yeah.
use that one. Sir.
Yes, yes. So there are people who use it regularly. Some people use it weekly once. Do you use any kind of indicator? Not a question, just out of
Yes,
curiosity.
yes.
Indicator for the ultrasonication?
No, sir.
There are some costly indicators available. What
Okay,
we use in our institution is a foil. The
okay,
thin aluminum foils in an empty load. You cut it
okay,
nicely into a square or rectangle, put it in
okay.
an empty load, and it'll
Yes,
have serrated edges and hole formations. That means your ultrasonication is working. So that is
okay.
number one. And for
Yes,
ETO, what kind of autoclave? This is for the listeners to learn.
yes, sir. Yes, sir.
ETO, what do you use, sir? EO or
So
whatever.
we have that even that strips the ITO packs. There is
Uh,
a change in the color, we can observe that.
Class 1?
So class 1 is mandatory at the. Can I share that? Okay, sir. The
Okay,
class
it
1
doesn't
will
matter.
paste it over the back of
That,
backside of the
yeah,
pack.
that will tell the
Over
expiry.
the yes, over the strip there is the indicators. Once the ETO sterilization process is complete, we can see that there is a change in the color of that strip.
Okay, so
The pack
many of the
itself.
places they do not use we use a class 4 indicator. It can be a
Okay.
BCD also. If you do not have class 4, because the class 1 is not this thing to say it has been
Yes.
said. The better to use biological for each cycle. But
Weekly
class 4
ones.
is available. Weekly ones, yes. If
Weekly.
class 4 is available, if class 4 is not available, every cycle we should need to have a biological indicator.
Then
And the most important thing is the set integrity is lost in the packing.
yeah.
Then, and most important for all the PGs to know why, Doctor, I said, Doctor, somebody mentioned about, yeah, Rolika said you must have a register, know which pack, everything. There is something called recall. So along with the
Particularly
pack, a lot of other things are gone. Recall is a short question for all the PGs. So whenever something goes wrong, all the sets issued at the same time should be recalled, like how we have it in the pharmacy, whether it's a contamination or expired medicine. Recall will prevent a major catastrophe from occurring. That's why you put one in the set, one outside the set, and if you have a bin, one outside the bin. So at all three levels, we will know. Just a few points for the residents and the young ophthalmologists. Thank you so much, sir. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thank you so much, Dr. Vijay Bhaskar, and thank you, Chandrasekhar sir and Nirmal sir also for all your expert comments on this particular topic. So we'll move on to the next lecture of the session. So I invite Dr. Pushpa Kumari ma'am to go ahead with her lecture, and this is on communication skills and how to break bad news.
And as we mentioned, ma'am, in the morning session, a lot of people mentioned that we have this bad news topic coming up in the next evening segment. So we are looking forward to your talk, ma'am.
So I am audible?
Yes,
Yes.
ma'am.
Yes. So good evening. Thank you very much to AIOS Guru Sangam team for giving me this wonderful opportunity to present a topic. This is the third time I am presenting before Guru Sangam platform. Previously, 2 sessions, I learnt a lot. It was very interesting and it is 100% successful. This time, the purpose of selecting this topic is that it is essential for all practicing doctor, resident and fellow. In era of artificial intelligence and robotic surgery, the social media is flooded with many information. So it is patients who are our customers. They have a right to know regarding their disease, their process and treatment plan. Though this topic is included under undergraduate, resident and fellowships curriculum, but it's not properly practiced at the ground level. Doctors learn it by seeing their seniors or by trial and error method, and they often land with some problem. It is the communication skill which differentiate equally qualified doctors. Due to communication skill only, a quack is more popular than a doctor in some places. So,
Ma'am, sorry to interrupt, but ma'am, your screen is not moving
no, I'm
forward.
not moving. I'm
Okay,
not moving.
sure.
So
Thank you,
this is
ma'am.
the
Okay.
introduction.
Okay, ma'am. Got it.
So my layout of presentation is in two parts, communication skill for ophthalmologist and then second part, breaking bad news in ophthalmology. So first, what is communication? The act or process of using words, sound, sign or behavior to express or exchange idea, thoughts or feeling to someone. It is a two process. Sender will send the message and receiver will receive it, and both will receive in same manner and same time they will give feedback. So it is a complete cycle. So communication is not a rocket science. It is more than a soft skill which is learned with practice. Then what is communication skill? It is a set of skills required for effective communication. It is a type of soft skill. It involves both sender and receiver. Both person have to perceive in same manner. Then For the PG clearance, what is soft skill or non-technical skill? It is a personal attributes that describes how you work and interact with others, such as communication, teamwork, and problem solving. Unlike hard skill like programming, which are often learned in a course, soft skills are developed through experience. It is transferable across different jobs and industries. They are crucial for workplace success and includes traits like a strong work ethics, adaptability, and emotional intelligence. How communication for the ophthalmologist is different from physician. As we are dealing with high volume patients load day to day, so we have very less time to communicate, but we have to give attention to the communication. Our patients are usually elderly with the poor vision and hard of hearing. Most of the chronic diseases like glaucoma, uveitis, diabetic retinopathy, they require long-term follow-up and treatment adherence. While prescribing glasses, the most of our complaint is due to wrong prescription or long adaptation, or if we are not communicated in a proper way. Counseling pre-operatively for any ocular surgery and also the choice of intraocular lens. So it is said that if you spend more chair time, you will avoid, you will sleep in a better way. Most of our ocular surgery done under local anesthesia, and patient is conscious of OT staff and doctors communication. So where we be aware of this all communication. Permanent visual loss due to, it may be either due to surgical complication or disease. It is a very painful situation and it is very difficult to break that news. We have seen that 60 to 70% medical error is due to poor communication, which can be reduced by effective communication. So why communication is important? To get and give information for consumers awareness, to get action, that is increased demand and expectation in public, to persuade patient for treatment, to change behavior of person and thereby the community, to ensure understanding of the person. We are also answerable in workplace. Suppose there's something mishappening, we are answerable to our superior or our institutional. In patient and hospital conflict, increased aggression and stress among people. Sometimes we have to communicate before media to deliver something, our achievement or mishap. In litigation fight in front of the court, so we must know how to communicate, what to say, and how to say. So what is the communication? How it is processed? It is a two-way process. The process of sending and receiving information among people. So message is encoded, then decoded, then interpreted, then again feedback is given so that a patient can be understood. So what is our communication goal? My first goal is to ensure understanding. Unless otherwise understand, we are not successful. Then to get action, to persuade, to get and give information, then thereby change the behavior of the patient and thereby the community. There are different ways of communication. They are divided in verbal and non-verbal. Among the verbal, it is speaking and writing. And non-verbal is body language and visual aids, by showing visual aids. According to Albert Mehrabians, there is a rule called 7-38-52 rule. In our communication, what we are delivered, words constitute only 7%, and the tone of voice 38%, and rest you will surprise it is 55%. It is about the body language, which we are not aware of it. So be aware. But in case of ophthalmological case where the person is visually impaired, there we have to use more words and balanced way. We have to tone our voice. And in case of body language, while we are showing the signage, we have to use large print like in visually impaired cases. So what are the types of communication? It is depending on the situation. In organization, it may be formal or informal. In communication, while communicating with the person or outside speech, it may be vertical, horizontal, or crosswise. In other way, it is oral, written, or gesture. So what constitutes the effective verbal message? It should be brief, succinct, and organized. It's free of specialist jargon. Like suppose I will say it is a malignancy. They will not understand. I have to say it is a tumor or a large mass we will go on progressing. Do not create resistance in the listeners. We have to listen actively, and they have to allow to listen, tell, and we have to be an active listener. There are 5 categories of non-verbal communication. They are divided: vocal clues of paralinguistic clue, action clue, object clue, space and touch. I will deal one by one. So what is vocal clue? So vocal clue, it decides pitch, tone of voice, loudness, rate and rhythm of talking, unrelated non-verbal sounds such as laughing, groaning, nervous coughing and sounds of hesitations. So these are very important. So while modulating our communication, it constitutes about 38%. This is the example of paraverbal message. Here is one example. I didn't say you are stupid. Here stress put on the say. I did not say you are stupid. Third, I didn't say you are stupid. So according to our modulation, the meaning of the word changes. Then action clue. Action clue, facial expression, eye contact, appearance, gesture, automatic reflex, movement and posture. This action clue is very, very important. Without telling any word, our facial expression gives a lot of this. Here, in like that, this is happy, sad, fear, anger. Eye to eye contact is very, very much important in the era of EPMS. While we are HIMS, we are busy in typing the things and we are not, and while looking at the phone, and if you ask any history to the patient, they felt neglected. So while taking any history or any communication, please keep your eye contact. And also at the same time, your facial expression by nodding, so that you are assuming that I am with you. Then gesture, then automatic reflex, then movement and posture. Object clue. So what are the object clue? Signal for someone to do something. Best example for this signal is that while we are moving in the traffic, if we communicate there by word, it will bring disasters. So we know that green light is to go, red is to stop, and yellow is to change. There, if we show signal, hand signal, anything, it is very difficult. So it is a standard, and as the person know, this is a standard signal. An object used to refer a person, a place, or object or activity. Like Taj Mahal, it will show it is a momentum for the love. Suppose a person, if we show Rabindranath Tagore, they will know who is that. Similarly, it requires a simple motor response like pointing, touching, picking up. Suppose a sir calling, what is your name? He will ask first. Then he will point next. Then they automatically understand whom to, and what to do and what to not do. Especially for children and people with deaf and poor speech, this object clue is very essential. Space, how close we sit or stand or talk to someone. So there are 4 spaces. Intimate, this is for the core, to care the partners or care the family. Then personal is for friends, extended family. Then social is acquaintance in the colleague. And public space, that is more than 12 feet, is for passerby or stranger. So we have to keep, while communicating with any person or patient, we have to be aware of our space. Then touch can be a key to unlock a patient's feeling. A tentative touch perceived as distress or reluctance. A positive touch is firm but gentle, should have professional purpose and to provide reassurance to patients. So they are different. So according to the culture, according to the area, we have to do that thing. Which is acceptable, which is not acceptable, we have to be aware of that. Associated body language facility. So what are the advantages of the associated body language, which will increase our rapport building? So greeting softly, establishing eye contact, listening attentively, maintaining open posture, leaning forward, nodding whenever appropriate, allowing patient to express, accepting emotional reaction, and comforting the patient or family. Here we are showing by hand holding or keeping the hand over the shoulder, it gives a great reassurance to patient. So what makes a good communicator? What we communicate, it must be very clear, we have to maintain the integrity and timing and also adequacy. What are the barriers to the communication? Semantic barrier, emotional or psychological barrier, organizational barrier, and superiors. What do you mean by the semantic barrier? It is a symbol with a different meaning. Badly expressed message, faulty translation, unclarified assumption, specialist language. Like here, I have shown 8. Somebody understood it as a 8 or infinity or wave, or some may think it is a structure of DNA. So what we speak, we have to explain it clearly. It has not got double meaning. Then psychological barrier, premature evolution, inattention, failure to communicate, distrust, undue reliance. We have to give some time to say. So it is said that physicians should not interfere before 18 seconds. So let them to speak. Organizational barriers. So there are certain organization policy, rules and regulation, status relation, and complexity. So we have to understand that thing, and accordingly we have to speak before any person or media or court. Personal barrier, attitude of superior, fear of challenge, lack of time, lack of awareness, unwillingness to communicate, lack of initiative. Here we are seeing two persons are seeing close together, but here this person keeping his hand over the face, it indicates he is depressed or thinking something else. And in other way, they are engaged with her mobile phone, and there is no communication between both. So this posture, this gesture itself indicates that they are not in the same mood. Main area of doctor-patient communication is consultation process, which is most important, health education and counseling, problem solving and decision making, breaking bad news. This will I deal in second part. Dealing with difficult patients or relatives, disclosing medical error and patient's referral. Out of all this, my main emphasis is on the breaking bad news. What are the benefits of effective communication? It will reduce friction in day-to-day working. Reduce conflict with staff, patients, and their relatives. It will reduce the risk of medical negligence allegation, as it is seen that 71% of legal claim for medical negligence is due to poor communication. So we have to be aware of our communication. Ultimately, it will give great patient satisfaction, which lead to we have to able to build rapport and win their trust, and thereby good teamwork, reduces stress, less burnout among self and our staff. Then there were professional satisfaction, name, fame, and money. What are the principles of communication? Listening, probing, observing, and information. Out of these four, listening, that too, active listening. I will say what is listening and what is hearing. It is a physical thing. You will only listen, only hear. But listening it is active listening. We have to listen for content, meaning, and intent, and also feeling and value. It is active listening. So, few steps about the consultation, counseling, and communication steps. So, I will give in short, that is initiating the session, gathering information, building relationship, explanation and planning, then closing the session. Here, explaining about their illness and involving decision making regarding treatment plan, because patient has a right to involve in they know their disease and their decision and what type of treatment they will think. So we have to involve the patient in decision making. Answering questions and clarifying their doubts. In some cases, we have to involve their family also. Suppose while we are breaking bad news or for long treatment, for the treatment adherence, we have to involve patient's family and their personal doctor or general practitioner also. Display respect for patient and caregiver. As we know, patients encounter with several person while he enters in the hospital till he reaches to doctor. So somebody misbehave or somebody do not give respect, he will feel bad about the hospitals, and our hospital respect will go down. So we have to display respect for the patients and caregiver. If we respect and empathy in the healthcare, there will be no violence. As we know in media, there are a lot of excuses regarding the physical violence against and verbal abuse against the healthcare worker. So by improving our communication skill, we can prevent it. Respecting privacy of the patient. So patient confidentiality and privacy is very important. It is a huge chapter. Just I will touch it because how to explain, how to diverse any diagnosis. So we have to maintain the patient's confidentiality and also privacy. Valuing the time of the patient. So we have to reduce the patient's waiting time by giving appointment, or if we are waiting, somebody has to attend there. So patient don't feel that there is a wastage of time. So in hospital, don't try to wait. Demonstrate willingness to engage in conversation. So we have to show positive attitude in healthcare. What is empathy? Empathy, because our patient don't want sympathy, they want empathy. So empathy is I know how you feel, a skill to understand people. There is a lack of empathy that is giving rise to poor communication and all sorts of error and litigation. So what special communication skill is required for ophthalmologists? So we have to addressing patient concern and queries in a proper way, because it is a different branch other than the physician. Practicing informed decision making. So in this case, informed decision making, we have to give consent in their local language and also to record, and most likely if it is a video consenting, it is 100% proof. Handling the situation when patient wants to seek second opinion. So don't discourage for seeking the second opinion. It is our protection. If he wants to seek second opinion, let him to go. While referring the patient, communicate effectively regarding his or her disease to the second physician. Communicating with the patient who has come for second opinion, so be aware of that. Don't say anything negative about your colleague, because suppose there is some complication has happened, tell them in a soft voice that it is a normal complication, it may happen with anybody's hand, and don't worry, it can be done, and there is a treatment. Suppose there is any nucleus drop and person has come for the second opinion, so you have to console in a proper manner and don't discourage your colleague, because sometimes it may happens to you also. So be careful for second opinion. What are the good practice tips? So we have to build rapport, practice transparency, address their concern, practice informed decision making, give realistic expectation. Don't give. So it is that he under promise and over deliver. Accept professional limitation. So we have to know. Suppose I am a cataract surgeon, there is a nucleus drop. So I have to tell properly that I am not able to manage. My VR colleague will do it. So let it go there, and he is a very confident surgeon. He will do your all job. Keep patient and family updated. Communicate what you document and document what you communicate. See, in NABS condition, it is very, very important to document anything. So due to document only, we can avoid any litigation at the court. Then coming to my second part, that is breaking bad news in ophthalmology. So again, it is what is the bad news, why and how. What is bad news? The news which adversely or negatively affect one's view of future. Most challenging communication task in healthcare. It requires empathy, honesty, and professionalism to ensure patients understand their situation and feel supported. Why it is needed? It is an essential skill to be learned and improved. It forms a part of clinical skill for doctors' training. Improves disease journey for both patients and caregiver and also doctors. It facilitates patient and doctor discussion and decision. Also empowers patients or relative for decision. Non-disclosure is no longer ethical. Previously, if anybody has a cancer, their family member, they will don't disclose to the member, don't. But now non-disclosure is no longer ethical, and it also reduces the stress on the doctor. What are the ocular conditions which are bad news? Out of this ocular condition, most important and most worst is permanent loss of vision. But I have divided into like this: light threatening means ocular cancer like retinoblastoma, then AIDS; vision threatening like glaucoma, retinal detachment, central retinal vein occlusion, diabetic retinopathy, central retinal artery occlusion, age-related macular degeneration, and macular hole, which can give rise to permanent loss of vision in long term if not attended. Lifestyle alteration like advanced cataracts and high refractive error, they may alter their day-to-day life and quality of life. So we have to make declaration about the diagnosis about the advanced cataract or high refractive error similarly. Iatrogenic error like surgical complication like nucleus drop, posterior capsular rupture or tear. Then how? What are the different methods? There are multiple methods, mainly in ICU setup or in cancer, like spike, ABCD, break, sad news. Same how? Then this is the different method. When ABCD, spike, and break. In our ophthalmology, we usually we are following this spike protocol. So what is spike protocol? It is a 6-step protocol to deliver bad news. It is given by Bale and Buckman. So these are same setting, perception, invitation, knowledge, empathetic, and summary. I will detail one by one. So setting up the interview first we have to do mental rehearsal, privacy, involve significant others, sit down, avoid distraction, make sure the patient is comfortable. Mental rehearsal, we have to go through the entire conversation in our head and prepare ourselves to face emotion. Choose appropriate word that can be used. This is our mental rehearsal. Anything when we are going to present today, while I am presenting, I have to do mental rehearsal. What to say, what not to say. Then physical setting. Ideally, separate room which is quiet. In our setup, maybe drawing the curtain around the bed, because if separate room is not available, or talking to relative in treatment room or outside the ward, maybe as possible. Then involve significant others. Ask the patient who they want to be alongside, whether they are family member or some patient they don't want to involve their family member. Then sit down, make the patient feel you are not in a hurry. If not possible, then at least eye-to-eye contact should be made. At times it is seen that while consulting, all patients, yeah, their members, they try to stand up. But while delivering any bad news, he may fall down after listening this news. So try to make a person sit down so that we can take proper care. Avoid distraction. It is good idea to keep away our mobile phone or keep them on silent mode. Ask others not to disturb you for the duration of the conversation. Make the patient comfortable. Be sure the person is not in pain or nauseated or sedated. If it cannot be overcome, then always address it. Make the patient feel we are aware of his suffering. Assessing the patient's perception. So before assessing so perception, how to know the perception? So we have to ask some queries, then listen their queries and comprehend their queries. So by query, ask open-ended questions. We should not ask closed-ended questions. So open-ended question, it will elaborate in a detailed way. But in closed-ended, there is two answer only, yes or no. What have you been told about your disease condition? What do you think that PET or CT was done? So again, listen, pay attention to the verbal and non-verbal language of the patient. Also comprehend, know their level of understanding, the emotion attached. Also help to find out if the patient is engaging in illness, denial, or wishful thinking. So there are certain person, they will deny their diagnosis. So they are in a denial phase. So we have to understand that. Obtaining patient's invitation means aim to be determined how much information the patient wants to know. Somebody they want to know only diagnosis, somebody want to know prognosis, somebody want to know their detailed treatment plan. Example, are you a person who likes full detail or do you prefer just to hear about treatment plan? Would you like to know exactly what is going on or would you prefer the outline only? Offer further query or question in case they change their mind. Yeah, we can go to next session also. Then K for knowledge, that is, we have to give the knowledge in a chunk and check method. So what is chunk and check method? It is chunk when you have to information in a chunk, small break point. Then we have to check whether he is able to understand it or not. So get to the point, deliver information clearly and honestly in plain language. Here, no jargon, no doctor jargon or medical jargon. Be mindful of body language, avoid jargon and give a small chunk. Use warning source. Example, I am afraid. The results are not what we hope for. Pause frequently to allow processing. So we have to give some pause so that person can analyze what we have what we have delivered, and wait for reaction. Then address emotion with empathy. Observe and acknowledge emotion like shock, anger, sadness. They may shock, they may expose anger, they go to sadness. Use empathetic statement. I can see this is very upsetting. I wish I had better news. Allow silence and do not rush. Be mindful of your own response. Comfort the patient. Don't show your reaction. Then last is strategy and summary. Outline next step and ensure understanding. Offer support and follow-up appointment. Example, we will go through this together. You are not alone. Decision made or to be made. Need for further session. Use teach back technique. Teach back technique means we have to deliver the news in a chunk, then check. Then again we have to ask the patient in their own word, what do you understand about your disease? Suppose I have told you have to put this drop 4 times in a day. Then he have to say, what do you have understand? Then he will tell, I will put this drop. But suppose one color red food in 4 days. Then we know that he has understood. So this is the teach back technique. What are the special in Indian or so as we know there's a low level of literacy or language barrier. So we have to identify the level of literacy early and then tailor the information. Prepare in the native language and use a transcriber or translator if needed. Increase the use of picture here. If there's a low level of literacy, we have to increase the use of the picture. Discussing psychologically issue and stresses is still not a norm because we are not thinking it is a norm in our country. So we have to understand the family dynamics, ensure the absolutely confidentiality, offer appropriate counseling to both patient and caregiver. Illness is a family event rather than an individual occurrence. So we have to involve the family member. So understanding the concern of the family member and counseling them assumes more importance as they play a huge role in patient care and decision making as compared to outside country. Because here we are a joint family and we often involve the family member. So we have to see what is the situation and accordingly we have to act. Relatives not wanting to disclose the news to the patients. So what are the problems? There is the ethical aspects. Patient has a right to all clinical information. Hiding the diagnosis could lead to confusion and lack of trust in the patient. Patient want to know. But practice is what? Study done at AIMS has shown that 63% doctor agreed to hide the diagnosis provided the patient did not ask. Similar study done in Saudi Arabia shows that almost 70% of the doctors agreed to not disclose the diagnosis if the relatives demanded so. But solution is explain the ethical position and potential difficulties of the hiding diagnosis, ensure that any communication would be done sensitively and patient's demands respected. Being upset to an unfavorable diagnosis is a natural response, but most people adjust to that knowledge. So we have to communicate in a proper way. Few lines about the how to break news of death. Though in our ophthalmology it is very rare, but sometimes there are some death on the table while operating. So we must know how to break that death news. And being a operating surgeon or being a head of the department, it is the responsibility of the head of the unit who has a good rapport. He has to break the news of the death. So first, how to prepare in conditions where the death can be predicted, always prepare the family in advance. But here in ophthalmology, it is not predicted, so it is a sudden. Setting, quiet sitting, relative known to be healthcare system, relatively senior, clinician should introduce himself and start talking. Then foreshadow, I am sorry to inform you. Then break, use simple language like Rajesh is dead. Avoid alag way, passed away or left us. Then facilitate the grief reaction, like encourage expression of the emotion, encourage to talk about patient's illness and explain effort taken to save him. Appreciate efforts taken by family also, because at times family they think that they feel themselves guilty that we have not taken proper care, could have been shifted the patient to the other hospital. So it helps reduce the guilt and the self-blame. Use of religious philosophy like ultimately everything depends on God's grace might help to console relatives depending on upon religious background. Then how to arrange for the viewing of the disease. It is often said that if you are not in proper arranged way, some public disagrees evolve. So cover the body with proper clothes. Remove all life support like endotracheal tube, ventilator, cardiac monitor. Wipe the face and body neatly to remove blood and other secretion. If we not remove the blood or other secretion, the message will go that they have not taken proper care. Help the relative go through the official formalities like try to speed up the process of making death certificate, ensure smooth and timely handling of the body of the deceased along with valuables and personal belongings, help them to take the body of the deceased away as soon as possible. Then everything has a barrier in breaking bad news. Similarly, breaking bad news have a barrier. So it is doctor's individual characteristics, patient characteristics, then organizational characteristics. So what are the doctor's feeling of fear, anxiety, and stress? Doctor may feel that if I break this news, I may the doctor have a stress. So inability to handle emotional reaction of the patient, lack of knowledge and fear of making mistake, personal bias, taking responsibility and fear of being blamed, lack of adequate training in communication skill is the basis of this all. Why doctor is have a fear or anxiety? Because we are not adequately trained in communication school, communication skill. So it is my request, it is already in curriculum, but we have to take more attention. Then organizational characteristics is lack of physical space, time constraint, work overload leading to fatigue. Thus, communication may not be priority, but we have to give priority. Why do we care for the breaking bad news? Because it is an ethical issue and also to avoid the legal issue, and they have a human right to know about all their diagnosis, and it will indicate our professional efficiency also. So what are the do's and don't? So do's ensure privacy and confidentially listen and respect, use simple language and be honest, be sensitive to non-verbal language, allow for emotion. And what we don't, that overload with information, don't give false reassurance, withhold information. Withholding information for a lot of time, it will create their in public, and you will call that make judgment, that criticize, all allow distraction, distort the truth, and counterattack. So these are the things you should not do. What are the documentation? So again, documentation. It's important that accurate records are maintained of the conversation and the information and the detailed exchange. Here also again, we can video record. Assistance in the future care of the patient and enhance the communication within the multidisciplinary team, including patient's general practitioner. This record should be documented in patient's note also. The specific words used to describe the disease should be recorded. For example, tumor, growth, or malignant disease. There is a record which contains patient's name, address, hospital name, date and time of interview, location, whether it is done in ward or outpatient, name of those present, their family member who are present and their witness, position or relationship, what is the clinical diagnosis, clinical option for future management and immediate plan, detail of the words used when breaking the bad news, sign of authority, authorized physician, social worker, and also family member or MO. What are the additional tips? So additional tip is we have to maintain empathetic body language, avoid false reassurance or bluntness, document the discussion in medical record, arrange emotional support or counseling if needed. Common pitfall is that in vast one heavy load in outdoor patient, we have inadequate time or information. Failure to elicit patient's understanding or situation, giving news at doctor's speed, not allowing time for responses, false illusions about the future, allowing denial to remain, removing all hopes. So we should not remove all hopes. So I am presenting on a case scenario. A 24-year-old girl presented to eye clinic with poor vision in both eye for past 6 months. She doesn't have any known medical problem. On examination, vision in right eye counting figure and left eye 6 by 60. Intraocular pressure is 45 milli of mercury in right eye and 38 in left eye. Both optic discs showed advanced cupping with typical glaucomatous features. Visual field is very constricted in right eye and tunnel vision in left eye. Her condition is suggestive of advanced glaucoma. She requires maximum anti-glaucoma treatment and continuous monitoring of her IOP, intraocular pressure. Surgery is needed if IOP is not well controlled. She is currently preparing for NEET PG entrance examination. So this video is played by my DNB student with their permission.
Do you want me to speak to you alone or do you need
Is it
somebody
audible?
to speak with? No, doctor, I'm fine.
Yes, ma'am.
Okay, so how are you feeling?
Slightly, if you can increase the volume, ma'am.
I feel there's a lot of pain in and around my
Okay.
eyes and also headache. Sometimes I feel nauseating and
Yes.
also I'm feeling difficulty in driving. I'm not able to drive properly usually in the evening. And can you please tell me what has happened to me?
See, I have done all your tests. I have examined your eyes thoroughly. I have measured your intraocular pressure, which is the pressure of your eyes. And I have done your visual field perimetry. I have seen your retina and everything, every test points to just one thing. I think you have advanced glaucoma.
Glaucoma? Oh no, but nobody in my family has this. How did I get this?
The thing is that did you ever have any surgery to your eyes in the past?
No, never.
Any kind of trauma to your eyes in the
No,
past?
never. I never had. But sometimes I used to feel a little difficulty and in seeing and pain in seeing in the dark room.
Okay, so maybe it was developmental. Earlier you did not have so many symptoms. Now it has become more pronounced with your growing up, and therefore now you have more symptoms, more pronounced symptoms. So I know it is hard to understand. It's hard to believe, and but the thing is that it is the good news is that it is treatable.
Okay.
Yeah. First we'll go for medical treatment, and if that does not suffice, then we'll go for surgical treatment, which is surgery. Yeah.
Surgery?
Yeah.
Oh no, doctor. Surgery.
Are you okay? Do you need this?
So we have to pause. We have to allow the person for their emotional.
Do you want water?
We have to. We ask for the water, hand holding.
Are you okay? Can you proceed now?
Yeah, please.
Yeah. See, do not worry. We have involved a very renowned glaucoma specialist with us. Will be taking care of you along with us. So the thing is that it is treatable. The only thing is that it requires prolonged treatment and regular follow-up. So you'll have to come for regular checkups. And the thing about surgery is that it can be deferred if things go well with your medical treatment. Only if medical treatment does not suffice, then we'll go for surgery. So do not worry, okay? You're in safe hands.
Thank you.
So to conclude, the take-home message that here it is very well said. The doctor will see you now. I cannot promise that he will talk to you, but he will see you definitely. So this is the very well written picture. So recognize the importance of bad news, essential skill to learn and improve. All patients are different, so we have to customize. No assumption on patients' thinking or reaction. Stress on developing program for teaching. We have to do more curriculum where we can teach our juniors, our colleagues, and our fellow how to deliver bad news and how to communicate in a proper way, and we have to give stress repeatedly. So lesson to be learned from owls. What is effective communication? A wise owl lived in an oak. The more he saw, less he spoke. Less he spoke, more he heard. Why can't we all be like that wise old bird? Because here same theories apply. We have to speak less, we have to how to speak, then our body language. So we have to learn the lesson from owl to be effective communication and be a good ophthalmologist in our practitioner so that we can do our name and fame. I acknowledge my patients and DNB student, consent from patient taken, photos from the internet for the teaching purpose. And thank you very much.
Thank you, ma'am. Thank you so much for the elaborate coverage on communication skills and how to break bad news.
Stop there.
So the topic is open for discussion by the expert panelists. Dr. Prakash, sir, you want to
Yeah. I think,
add in?
Pushpa Kumari ma'am, the topic was very well covered. I think it was
Thank you.
expensive, and you have covered both the things like communication skills and then breaking the news. I think we will divide this breaking the news in three criteria. First important is telling the diagnosis like diabetic retinopathy, glaucoma, and retinal detachment
Life
retina.
changing, life
I think
changing.
these are the routine things, and we need not worry about that. The video you have shown about it. Next two things are very important. Next one is iatrogenic things like nucleus drop and PCR. That has to be tackled in a nice way, but still it can be tackled. And the third thing is the worst thing, like to tackle the situation of death. Like about discussing and what lecture you have given, it is worse to experience the situation. So whenever it is for clinician or practitioner, ophthalmologist, when the situation comes, I think it is different experience for different situation. It is not the similar one. So the worst situation is about the death, and about that I'll speak a little bit, because talking about a nucleus drop and PCR you have covered extensively, and that is perfect what you have told. Whenever it is the news of death, it is very difficult to handle. The junior person in the hospital, suppose is telling about that news of death, it is not the perfect thing. I think senior person should take the lead. It is a team we should break that particular bad news. And in Europe, when you are telling that bad news to the patient and relatives, I think all the staff, all the doctors in that particular hospital, they must be told the situation. Because suppose there is a chance of violence, probably that all the team of hospital and doctors and staff will be at your help. In most of these cities, like in our city of Pune, when I'm working for Indian Medical Association, we have formed rush teams. The rush team for that particular area doctors, they have got the WhatsApp group. And whenever there is a situation, they're coming to help. Suppose there is a group of 15 or 25 doctors at that particular situation. That is the very great help for doctor and that hospital. So before breaking the news, you have to be very careful. Like the staff, junior resident, doctor, and HOD, they should be on the same page. There should not be any difference of opinion. Each person should speak in the same language and the same version of the situation. So whenever there is a difference in telling of different person from different perspective, probably it will create a trouble. If it is a situation like that, you have to take help a lawyer. And routine lawyer is not important here. It is the medical legal lawyer, the person who is a doctor and who has done law. Though not practicing, that is a medical legal consultant. So at KIS level, probably Dr. A. Deshpande and few more people are there. So you should take help of the medical legal consultant. Probably he is not able to present your case in court of law, but he will be guiding you for those medical terminologies. And in that situation, the documentation of all the situation is very important, the chronology. Then whatever notes you have been writing, even if the situation is very bad and worse, the writing and documentation should be perfect. And in that particular situation, empathy towards patients and relatives, what you have talked about, handling the patient and relatives, that is very nice. Even involving the police in that particular situation. Suppose there is a death. There are two situations. Patients, they say that we do not want postmortem, but insist for the postmortem whenever there is a death. And for that particular situation, you may feel that if the postmortem is not done, you are saved. It is not like that. In future, probably that postmortem report is going to save you, because if you are not doing the postmortem, it is going to take you to the trouble. And in the routine situations like nucleus drop and precedent and other diagnostic situations of ophthalmology, you can help the patient to have the second opinion. The second opinion may be of your choice, another consultant, or patient may ask for another ophthalmologist of his choice. And in that situation, if there is a complication which has happened at your hands, probably the charges can be negotiated, empathy and sympathy. You can follow that patient till the end, and those relatives and patients should feel that you are taking proper care in that patient. I think this was additionally what I wanted to say. Thank you so much.
Thank you so much, sir. Chandrasekhar, sir, you want to add any comments?
Yeah. Yes. It was a very comprehensive presentation, madam. So it was very, very comprehensive. Thank you. So basically, and we all have to understand it is verbal and non-verbal, which will both play a role. I keep a very harsh face and say good thing it has no value. And if I say something bad, with a nice smiling face, both should be in sync. And second thing is, as sir said, it should be a culture of the hospital the way it is happen. It cannot be taught one to one. It should become how the receptionist will talk, how the doc. If there is a difficult situation, they should know it should be spoken only by the in charge or by the administrator. Because everybody is in a different line, medical legally we are finished. So these are the things, and as you showed, role plays are the ones which will help to define these communications in a hospital, and they should all be in the same page, and the thought process should be good. So thank you so much, madam. Thank you.
Thank you, sir. Thank you so much. So with that, I think we have come to the end of today's session. I thank all the speakers and the expert panelists as well, because you have given us your time to be here on a Sunday evening. All right. So thank you so much.
1 minute, Farnas. Dr. Nirmal is a legal expert. He has finished his course, so he helps us a lot, and Tamil Nadu. So just wanted to tell that.
Okay, I think sir is back here. Sir, do you
Yeah.
want to add a few comments about the previous topic?
No, for us, I think Madam has extensively covered the entire communication program. So the good thing is now this communication skills are taught from first year onwards. So thanks to the NMC and medical universities taking this and including the aided program from the first year onwards. So that includes the way of communication and conveying the bad news. And sir, as rightly said, the bad news when we convey to the patients. So a few practical points. Always there has to be privacy. So take the patient and their attenders to a secluded area and give them some time to accept the message. So whatever bad news or information you want to give. The second point is give some time for them to recover from the bad news, and then try to be empathetic as well as sympathetic, and see how you can take the communication forward towards vision rehabilitation or helping the family and the patients. Third is so always better to document this communication so that the patient as well as and their family are understanding this communication has been documented. A good thing is to have a videograph. So many hospitals have a videograph system in the consent as well as counseling this kind of special situations. NABH in turn have made this into a standard. Effective communication is a standard now in the second edition ICAT standards as well. And particularly this conveying bad news and special situation handling is a standard to be documented as well as taught to the entire staff. So that is the level of focus we have given to effective communication in healthcare settings. And Prakash sir have already highlighted about the medical legal issues. It's very important that communication, counseling, and consent is documented well and taught to our practicing professionals.
Thank you, sir. Thank you so much.
And a word about both of you. You're doing a wonderful job. I've been watching this GuruSangam since yesterday, both the previous program. Wonderful work, Dr. Fatnas and Dr. Olika.
Let me just on the finishing note. I think all three speakers, they spoke very well, and I must congratulate AIS for taking this initiative of GuruSangam, and both the moderators, they have done tremendous job, and we must congratulate AIS for taking such topics because these are useful for our AIS members, not only seniors but juniors and upcoming ophthalmologists, because they need to know all this, and not only from their point of view, and we learned a lot from today's talks. I think there was so much to learn. So best wishes to this series of GuruSangam, and thanks to all office bearers for giving us the opportunity. Thank you so much.
Thank you,
Thank you
sir.
so much,
Thank you
sir.
so much.
Thank
Definitely.
you, Dr. Santosh Anwar sir, and the entire team of youngsters for this wonderful opportunity. So, God bless you all. Thank you.
Thank you, sir. Definitely the
Thank you all.
topic
Good night.
selection. Okay, yeah. The topic selection and to whom the topics are given also are like very well done, I think. All right. Thank you, sir. Thank you, everybody, for joining us on this Sunday evening. We'll see you next weekend, Saturday, 29th November, with fresh set of topics. And until then, bye from Farnaz and Dr. Rolika ma'am.
Thank you.
Bye. Good night. Good night.
Good
Good night.
night. Good night,
Okay.
everyone.